Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a cataract with grade 2 nuclear sclerosis. Let us observe this surgery. This is the main incision on the posterior aspect of the limbus. This is a 2.8 mm steel keratome. And now 2% hydroxypropyl methyl cellulose is being used as the viscoelastic substance in this case. Here it is. The SPMC is injected into the anterior chamber, and now a side port is made on the left side of the main incision, and in this case only one side port was made. And now the anticapsule is incised with a 26 gauge bend needle, and then a utrata forceps is used to hold the capsular tag raised, and a continuous curvilinear capsulorhexis is done. This is an adequate sized rhexis of about 5.5 mm. Now this is hydrodissection. Fluid wave goes to the opposite equator. Hydrodelineation has also been done, and now the nucleus is rotated. In soft cataracts, it is possible to hold the, in grade 2 cataracts, it is possible to hold the nucleus at the center, because at the center the nucleus is the hardest, and this hard part, the central core of the nucleus, can be held with low vacuum and the nucleus can be chopped. Let us see. Some superficial cortical lens matter is removed. Now the handpiece is turned. Bevel is now towards the cornea, and just one or two scalps have been made in this case in front of the main incision, and now the nucleus is held at the center with low vacuum, and the nuclear mass is chopped, and in this case very minimal ultrasonic energy was used to emulsify the nucleus. Vacuum used was 450 mm of mercury. Flow rate is 45 ml per minute, and ultrasonic energy was set at 60%, but since it is in linear mode, we can control how much energy is to be used by our footwork. Now the epinucleus has been removed. It is very much, we have to be very cautious when you remove the epinucleus. You must hold only the anterior part of the epinucleus sheet, the part which is just under the anterior capsular rim. Sometimes we may not be able to hold it. In that case, we have to do hydro again and manage the epinucleus. In this case, I am using a 23 gauge Simcoe as coaxial IA, and I'll try to remove the whole of the cortex through the main incision. Let us see if we can do this. Yes. Now go to the left, and now the subincisional cortex. Just tilt the cannula in such a way that we can hold a portion of the cortex and push it centrally. Yes, the cortex is removed. So the Simcoe cannula has been used as a coaxial irrigation aspiration system. And now I am using the irrigating probe of bimanual IA for polishing the posterior capsule. We can call it hydro polish because we are using the irrigating jet of fluid to dislodge the lens epithelial cells sticking to the posterior capsule, and thus we are polishing the posterior capsule. So this can be called hydro polish. 2% hydroxy propyl methyl cellulose is injected again to fill up the anterior chamber and the capsular bag, and then in this case a monofocal single piece intraocular lens from Hoya, Japan is being used. This is a beautiful preloaded system compatible with 2.2 mm wound, and when the wound size is 2.8 mm, the tip of the cartridge goes into the anterior chamber very easily, and the lens is safely delivered in the anterior chamber and it goes into the capsular bag. A Sensky hook is used to dial the lens, and if the trailing haptic is not yet in the capsular bag, it is just pushed into the capsular bag. And now the Simcoe cannula is being used to remove a portion of the visco that has been used just before implanting the intraocular lens. When we have to use both hands to deliver the lens, like in this kind of cartridge, we have to rotate the piston clockwise to deliver the lens in the anterior chamber. In such cases we have to use visco, and that visco has to be nicely cleaned. See, I have gone behind the IOL and irrigating the capsular bag. Now I am irrigating the anterior chamber. So we can very nicely clean the anterior chamber, and now I am using the irrigation and aspiration together. This is only the irrigating probe to remove the visco from the anterior chamber. Again I go behind the IOL, irrigate the capsular bag, because lot of visco may be trapped behind the intraocular lens. Unless we remove that visco, the intraocular pressure may shoot up and the patient will be very uncomfortable. This is a bit of moxifloxacin. The sight port at around 2 o'clock is closed by hydrating corneal stroma on either side of this stab incision, and then a final lavage of the anterior chamber, and then the anterior chamber will be formed very nicely by this 23 gauge Simcoe cannula. Again I am behind the intraocular lens. And now is the time to form the anterior chamber. Anterior chamber is very nicely formed and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.